It's a real pleasure to speak with you today, and this is quite an exciting time. And I think Dr. Goldhaber showed this slide, and I think this really was where we were at for almost 60 years, where we had a drug that was approved in 1954, the only available oral anticoagulant, and there was no progress in that field for over half a century. And that's pretty incredible in the field of medicine. It's very hard to think of another class of compounds where that's true. Think of all the iterations of antibiotics that have gone on in the last half century. And one of the problems, we know that warfarin is very effective, but in clinical practice, it doesn't seem like we're doing a very good job. Dr. Goldhaber showed this slide. When you look at patients who have a stroke, a preventable stroke, 90% of patients are either not taking warfarin or they're not therapeutic with regard to their INR. And so obviously this has been a big target in the research areas, pharmaceutical companies, and if you go back to the labs of many of these companies, Boehringer Ingelheim, Daiichi Sankyo, Johnson & Johnson, and the chemists were trying to design something that would improve upon warfarin, there were some easy things you could think of. Once daily dosing, a stable dose, everyone taking approximately the same amount. It was a rapid onset, so as soon as you took the medicine, you were effectively anticoagulated. Minimal interactions with food and drug. Dr. Goldhaber mentioned there are hundreds, if not thousands, of interactions with warfarin. A predictable effect, so you wouldn't need to monitor the blood every month. Safe in patients with renal disease, and rapid offset. So if someone showed up to the emergency department or needed a procedure, you wouldn't be stuck with someone being over-anticoagulated for several days. And so what I'm going to talk about today is really just the explosion of advances in medical science in this field in the last 2.5 years. And all of the new agents, instead of targeting sort of promiscuously across the coagulation cascade, actually focus on just one of two different parts of the coagulation cascade. So there's the factor Xa inhibitors, which is a critical enzyme in the coagulation cascade, and there are three agents that have either been approved or in late-stage clinical studies, and that's rivaroxaban, apixaban, and edoxaban. And then, of course, there's a thrombin inhibitor, dabigatran, which is the very distal part of the coagulation cascade. Now, one of the important things as you go through the exhaustive amount of trial material and things that have come out in the lay press is that these agents are very similar, but they have some important differences. As I mentioned, the most important difference is probably that they affect two different pathways. Dabigatran is the only thrombin or 2A inhibitor. The rest are 10A inhibitors. But they all are rapidly active. So if you take a dose of these medicines, within 1 to 2 hours, you're fully anticoagulated, which is quite different than warfarin. They have very different bioavailabilities, though, and interactions with both the cytochrome P450 system, which is the metabolism of most drugs, and, of course, protein binding. And their half-lives are actually quite similar, although these drugs are dosed either once daily or twice daily, and there's a big debate in the literature if this is important. And they also differ in renal elimination, and this is quite important because with warfarin, it's not renally cleared. So this is an issue that we've had to struggle with, and this is certainly an issue we need to think about with these new agents. So I just want to give you a broad overview of the trials we're going to discuss, and these are the basic, form the foundation of some of the recommendations you see now coming in the guidelines. There are 4 phase 3 trials with novel anticoagulants in atrial fibrillation. The first to publish, and we'll review these in detail, is the RELY study. That's with dabigatran, the 2A inhibitor. Then there's the ROCKET-AF study, which is rivaroxaban. The ARISTOTLE study, apixaban. And then the study that I work on with the TIMI study group, Brigham Women's Hospital, that's the ENGAGE-AF study. Now, these studies are enormous. They range from 14,000. Our study is actually over 21,000. If you look at the slide that Sam Goldhaber showed, those patients, you added up all those patients in the warfarin trial, there was about 3,000 patients total. If you add these up, you're almost at 70,000 subjects who will be randomized into one of these trials. So really an incredible, the size of these trials are just mammoth. Many of them were studied in 2 different dosages, but as I said, they vary. Some are given twice daily, such as dabigatran, apixaban, and the rivaroxaban and the edoxaban compounds are given once daily. They have variable adjustments. Some of them did not dose at all for renal insufficiency or other compounds, while other compounds have a dose adjustment. And so I think part of the excitement of this talk is really going through some of the literature in the clinical trials. And as a clinical trialist, when I spend my career doing that, it's actually quite difficult to digest all of this information and to figure out what are you supposed to do as a physician, a nurse, a patient who either has atrial fibrillation or is treating someone with atrial fibrillation. And I hope by going through these slides we get a little bit more granularity and a clear concept of sort of where this field is going in the next 4 to 5 years. In the RELY trial, we were quite excited because this was the first proof of principle that we could potentially improve upon warfarin. Again, a huge study, over 18,000 subjects, randomized to one of 2 doses of dabigatran, a low dose and a high dose, or warfarin, and again with a target INR of 2 to 3. And amazingly, although we were worried we weren't going to see this, the very first trial against warfarin showed that a new agent, dabigatran 150 milligrams, the high dose, was actually superior to warfarin in reducing stroke and systemic embolic events. And that's really quite an amazing result. I think we all assumed that these drugs would be similar to warfarin, but we had the first glimpse that not only would these drugs potentially be an alternative, but may in fact be better. And the low dose was non-significantly different than warfarin, but clearly equivalent. Now, one of the amazing things that we see is that when these drugs were designed, they were designed to reduce ischemic stroke. So we know when you have atrial fibrillation, you form a clot in the atria in the heart, and that clot can get ejected out of the heart, and unfortunately the first organ it sees is the head. And so we're trying to prevent embolic strokes. But actually the reduction in embolic strokes with these agents was quite modest. We see that dabigatran for the high dose had about a 24%. But what we saw, which was striking, is they had 60 to 70% reductions in the risk of hemorrhagic stroke or bleeding stroke. This was not anticipated. And we actually still don't know exactly why this is. And you'll see a recurring theme in my talk that all of the new agents seem particularly good at reducing bleeding in the brain of all kinds. And I think that's very important because that's the worst complication of giving someone a blood thinner. If we look then, when you give a blood thinner, we obviously want to reduce strokes, but we worry we don't want to cause bleeding. And this drug had a very similar bleeding profile to warfarin with regard to major bleeding. But as I mentioned, when you looked at intracranial hemorrhage, and obviously the hemorrhagic stroke is a component of that, again, you're seeing 60 to 70% reductions. There was a significantly increased risk in GI bleeding with this drug, and that's thought to be due to the fact that this compound is coated in a tartaric acid core because there's very poor bioavailability. So it's thought that patients with peptic ulcer disease or severe dyspepsia or reflux may not tolerate this particular compound that well. And there was a non-significant increase in myocardial infarction, and this has engendered a huge debate in the literature whether does dabigatran potentially increase, although a very small amount, the risk of heart attacks? Or is it just that warfarin is actually pretty good at reducing heart attacks and maybe dabigatran is less good with respect to this endpoint? I think one of the most important things that we learned was that even in patients who we thought to be at low risk, they still benefit the same from using this drug. So whether you are a high-risk patient, CHADS-2 score a risk of 3 to 6, or a low-risk patient, 0 to 1, you had the same benefit from these drugs. And I think that's very important because 40 to 50% of patients with atrial fibrillation have a CHADS-2 score of 0 to 1. And currently, we would not be offering them all anticoagulation. So as Dr. Goldhaber mentioned, this is a real paradigm shift. We really have to start thinking about what truly is low risk. And if we have safer agents, should we be extending those agents to patients we previously thought they were at too high a bleeding risk and weren't going to benefit? One of the things that's very, very difficult about understanding any of these trials is that you're comparing them to a drug that requires you to manage it to an INR of 2 to 3. And so if you use warfarin very poorly in your study, and everyone has an INR out of range, it's not very hard to beat warfarin. And so you want to make sure that the investigators in the trial do an adequate job and treat everyone to an INR of 2 to 3. And what you see is, as expected, that there's less of a benefit in patients who are relatively well controlled. Now, I'll tell you, one of the tricks of clinical trials research is if you divide the groups by larger numbers, so you separate it into 4 groups, you get a negative p-value, which is basically a non-significant value. But when you look at just patients who are well controlled or not well controlled on warfarin, it does appear that patients who were poorly controlled at warfarin, if you look up here, dabigatran is very effective. You have a 43% reduction in stroke and systemic embolism, while patients who are very well controlled on warfarin, they have much less of a benefit, approximately 5%. And we know this because even if you compare warfarin to clopidogrel and aspirin, and so here is warfarin, oral anticoagulant, here's clopidogrel and aspirin. If you use warfarin poorly, subjects with a time in therapeutic range less than 65%, there's no difference between giving people antiplatelet agents or warfarin. Where if you use warfarin well, you see there's a dramatic reduction in the risk of stroke. One of the other things we learned is that the benefits of these new drugs appear to be the same if someone has been using warfarin for a long period of time or whether they have never been on an oral anticoagulant. And so this is very important because people thought maybe these drugs will only be good in someone who's never taken warfarin. After all, we have no idea which patients in our practice, when we give warfarin, who will bleed and who will be able to tolerate it. We know a lot of people don't do well on warfarin. And so it was very reassuring to see that not only do these new agents work in patients who are naive to any anticoagulation, but it's effective for all patients. And one of the important things is we know and Dr. Piazza is going to talk about cardioversion and whether we get patients in a normal rhythm. These patients are very safe in the cardioversion process. And because of the strong data from the RELY trial, dabigatran was approved approximately a year and a half ago for prevention of stroke and atrial fibrillation. Only the high dose was approved in the United States, 150 milligrams twice daily, although the FDA does allow a dose reduction to 75 milligrams in patients who have renal insufficiency. And this has already been incorporated in the 2011 updated guidelines, which basically say a class 1 indication for dabigatran as an alternative to warfarin in patients with atrial fibrillation. Now, the first 10A inhibitor to come to trial and report their results was the ROCKET AF study. And this was actually one of the most confusing trial results that we've had in the last 5 years. And I won't bore you with too much of the statistics. But when you looked at this results, when they took the patients who were taking the drug, and so when you only analyze the results in patients who were actually taking both therapies, this drug was very effective. There was a 21% reduction in stroke and systemic embolism. But when you looked at all of the patients in the trial, regardless of whether they discontinued the drug, there was a non-significant improvement. And so this is not as a robust, not as a strong result as we saw in the RELY trial. And one of the worrisome things that we've begun to notice with these compounds is that there appears to be an excess of events when you come off of these drugs. And so one of the things that we didn't like about warfarin is when you stop it, you're anticoagulated for a long period of time. But there may be a potential that has some benefit because if you miss a couple of doses of these drugs, you have zero anticoagulation in your body. And so this started to raise the specter of what do we do with people who miss doses? Are they then having increasing risk of stroke? And I think the jury is still out on that. If, again, one of the things that we saw in RELY, if we look at the reduction in ischemic stroke, very modest, only a 6% reduction. But if you looked at hemorrhagic stroke, dramatic 60 to 70% reduction. So this is, again, a common theme. All of these drugs have a very similar effect on bleeding in the brain. And similar to the RELY study, when you look at major bleeding, again, very similar, non-significant increase. But when you look at fatal bleeding or intracranial hemorrhage, dramatic reductions. So it appears to be both the 2A inhibitors and the 10A inhibitors are much safer with regard to serious and life-threatening bleeding. And again, when we look at patients who are well controlled on warfarin, the results vary somewhat. Again, when you read the papers or the literature, you'll hear it doesn't matter when patients are well controlled or not. But when you really look at the data, we still, I think, don't know what to do with patients who are well controlled, because their risk of event is a lot lower, their risk of stroke is a lot lower than patients who are not well controlled. One of the important things about the ROCKET study is that they incorporated a dose adjustment for patients with renal insufficiency, and we saw that in patients who were dose adjusted to a lower dose, that they had the exact same benefit of patients who were in a high dose. And because of this strong data, rivaroxaban went to the FDA and was also approved for stroke and prevention atrial fibrillation. So after almost 60 years of having only one drug, we now have 3 in our clinical arsenal. And again, the FDA allowed a dose adjustment for patients with renal insufficiency. Now, the third factor Xa inhibitor to come to trial was apixaban. And apixaban did a very interesting thing. They did another trial first in patients who could not tolerate warfarin. So they weren't comparing themselves to warfarin, but they instead compared themselves to aspirin. And of course, apixaban beat the pants off of aspirin with respect to stroke. And that's not surprising to us. We've known probably for 30 to 40 years that warfarin is better, or any anticoagulant is better than aspirin. But what was quite surprising is the right part of this panel. Apixaban seemed to have similar bleeding to aspirin. And that was really quite striking, because again, this is not warfarin. This is saying that an anticoagulant, a full dose of a blood thinner, has a similar bleeding profile to aspirin, just single antiplatelet agent. And so we were all very anxious at the European Society of Cardiology 2 years ago when the ARISTOTLE results were published, which was apixaban compared to warfarin in atrial fibrillation. And again, similar to RELY, had a superior outcome. So apixaban was superior to warfarin in reducing stroke. And again, though, the same pattern. Only a little bit better with reducing embolic stroke, much better with reducing hemorrhagic stroke. And again, similar pattern. If you look at intracranial hemorrhage or ISTH major bleeding, which is just another bleeding characteristic, you saw that results were lower. And this was actually the first drug that showed significantly less major bleeding. All of the other drugs showed a similar bleeding. And on the prior slide, I didn't mention it, but this was also the only drug to show a statistically significant reduction in mortality. And so less patients statistically died in the apixaban group than warfarin. Now, I would like to caveat, because people will say, well, then that means apixaban is better at saving lives than these other drugs. That's not actually true. If you look at the relative reduction in all of these agents in reducing mortality, they're actually quite similar, about a 9 to 11% reduction. But if you add 1 or 2 patients to both groups, you move the p-value from significant to not significant. And so overall, I think the pattern of results with all of these trials is more similar than they are different. And we saw the same pattern, though, when we looked at patients who were well controlled. They do well regardless of whether they're on apixaban and warfarin. There's something about those patients. Maybe they come to clinic all the time, or they're very good about taking their medication. They seem to do better no matter what agent you put them on. One of the things that we do as clinical trialists is to say, what are we doing with these 3 trials? How do I know whether, if I'm a patient, I fit into one of these categories, or if I'm a physician, which patients fit into which trial? And one of the important things is that these compounds and these trials are different. And I think they enrolled different types of patients. They were different risk patients, and this affects some of the differences I've talked about in the trials. And I would just like to point out that the last trial that will be published will be the trial that we work on at Harvard Medical School, and that's the ENGAGE-AF trial, and that's with edoxaban, which will be another Xa inhibitor, and we're very excited and hope this shows similar promising results. And so I just wanted in one slide to give you an overview of what we've learned from all of the trials at one time. So you could go back and sort of look at this slide and say, this is all I need to know about all of the 15 papers that have been published in this field. And again, this tells you that these are the names of the trials, RELY, ROCKET, and ARISTOTLE. It gives you the names, the doses. And again, it shows you that both Rely and Aristotle had superior results. So those two drugs show that they were better than warfarin. The bleeding was similar in all of the trials except for Aristotle, which actually showed less bleeding. And as I mentioned, Aristotle was the only trial to show a significant reduction in all-cause mortality. But again, there were very similar reductions in the other groups. And I think one of the take-home messages that I think got missed in the lay press is that these drugs are actually very similar to warfarin in reducing ischemic stroke. Warfarin's pretty good. That's been around a long time because it's a good drug. Hard to use, but effective. And the reduction in intracranial hemorrhage is, I think, what drives the results. So just to conclude, when these drugs have been used in clinical practice, there are some important limitations. We've realized that the elderly may be at particularly increased risk because they often have lower renal function and they'd be more likely to bleed. And that this is important when patients present, especially with trauma, because we have no reversal agents for any of these drugs. And of course, we need to know how to use these drugs in patients who have acute coronary syndrome or coronary disease because we excluded all of these patients in the trials. And I'd just like to conclude that some of the questions that will be left over from all of these trials is, now what is low risk? Should we really be anticoagulating almost everybody with atrial fibrillation except if they have a CHA2DS2 VASc of 0 or 1? And I think, what do we do with patients who are on warfarin who are well controlled? Should we really be switching everybody? And I think that's an open question. And although we hated not being able to monitor the level of anticoagulation, it's actually very comforting. When a patient shows up to the emergency department in trauma and they say they're on dabigatran, I have no way of knowing how anticoagulated they are. And so the INR is very comforting in an emergency setting. And of course, one of the most important things that we have to struggle with is cost effectiveness, because these drugs are significant out-of-pocket expense for patients. So although if you decrease the amount of bleeding and hospitalizations, overall healthcare society as a whole may be cost-effective, it's very different when that cost burden is shifted to a patient. And so I think, just to conclude, because I know we're about out of time and taking questions, I think these therapies are incredibly promising. They're much safer than warfarin with respect to intracranial hemorrhage, and that is the most important adverse event from warfarin. There are important differences with these agents, and I think it's going to take several years for us to sort them out. I do hope that we have a reversal agent for these drugs, because until there is one, I think clinicians are going to be very hesitant about widespread adoption. As Dr. Goldhaber mentioned, warfarin is still fighting, and we have yet to see if warfarin may be even better than we've used it before with the help of genotype-guided INR management. And I think Dr. Goldhaber was right on that the risk prediction strategies are a thing of the past, and the new CHA2DS2 VASc score will be incorporated in the United States within the next iteration of the guidelines. So thank you for your attention.